This
Dr. Lalit Verma.
the reason we designed this session was about TIPS. I said in the beginning, it's the practical tips which we want to discuss. Maybe we want to learn also and offer some tips also. Aim is to share. You see, everyone will have some tip to offer. Aim ultimately is to improve our practices and benefit to the patient. I'll not discuss about endophthalmitis in detail, but believe me, it's a disaster. Rajesh, today I learned that, I thought only endophthalmitis is an emergency and CRAO is the emergency, but today you taught that infective keratitis also is an emergency situation. But the issue in endophthalmitis is if not managed in time and properly also, a lot of people keep giving topical drops, subconjunctive injections repeatedly, and result can be this, which is phthisis bulbi. This is what we don't want, and the whole purpose of this session is tips. And believe me, if you are an operating surgeon, the shadow surgeons are there, they keep smiling every time. But it is the operating surgeon where the smile goes down, and my family, once over I see endophthalmitis, my entire family will know kuch gadbad ho gaya aaj, and why is the mood so unhappy. So we all know intravitreal antibiotics is the mainstay. Results are very good if you inject early, and provided you are lucky that organisms are sensitive. Punita was telling about sensitivity and cocktail kind of treatment, but organisms has to be sensitive to whatever you are doing. If not, then vitrectomy is the ultimate answer. But before we go for prompt treatment, the aim is to diagnose it very early. You see, you have to diagnose very early so as to, because treatment we know, either it is intraocular antibiotics or vitrectomy. But diagnosis is what is often delayed. And this delay is despite, we having pre-op measures, per-op measures, betadine. We use drapes to isolate lashes. Good wound construction is one thing. And a lot of people, today morning we are having discussion about the role of intracameral antibiotics. Cefuroxime, vancomycin, latest is moxiflox. But despite all this, believe me, management of endophthalmitis depends on early this thing. So therefore, I have in this 10 tips for management. First point is to differentiate from the task. Second point is prompt injection. And third is do not delay vitrectomy also. Documentation is important primarily because to save you in the court of law. Court of law does not say that every patient has to improve. Court of law just says that you have managed it appropriately. That's all. Patient may still have phthisis bulbi, but if you have given the intraocular antibiotics, no court can sue you, believe me. But you have to document. You have to write it down, intraocular vancomycin given. Post-op day 1, seen this thing. If you have followed a protocol, believe me, no judge can sue you. But the key issues always are delay. People keep delaying. People keep thinking this is reaction only. They load with steroids. A lot of people are egoistic about telling no follow-up surgery. I heard this dialogue that cataract surgery karaya, but no follow-up is not required. If you have problem, then you come. But believe me, follow-ups are required for initial few days. One delay is of diagnosis because we have to differentiate why is the patient having reaction. Second delay is not giving intravitreal treatment. So rather than following up with drops or subconjunctive injections, you have to give injection at the site. That is what we learned. I was just talking to one gentleman in one of the sessions. He's saying there is subretinal abscess. So I told him, you go with the 42 gauge needle and go in behind the retina also. So because targeted therapy is the need of the hour in this. Because no amount of oral antibiotics or IV will reach, vitreous in a sufficient concentration. Like this patient was treated as inflammation because of this multiple KPs here, but turned out to be infection, and ultimately we had to do vitrectomy in this. This patient, young lady, operated RK a long time back, had a cataract surgery and was rushed for an emergency kind of vitrectomy. But this patient turned out to be pure inflammation and no infection at all. And the way we manage, I'll just let you know. So why we should differentiate sterile versus infection? Because both of them are different entities. One requires loading with steroids, the other requires intraocular antibiotics. And TAS, we all know its history, how it was described. I personally think every patient who undergoes cataract surgery has some amount of reaction, which is some amount of TAS is definitely there. Because all this, whatsoever you put inside the eye, some inflammation will definitely be there. But mild patients of TAS, they improve with routine treatment. All of us give antibody-steroid combination. These patients improve. But finding a etiological factor in a patient of severe TAS is a challenge because there are so many of them. A year back, AIOS received complaints from nationwide, virtually epidemic. So many patients were reported with TAS, but believe me, ultimately could not isolate what's the wrong. Although one particular IUL was blamed, but that IUL also we could not finally conclude. So there are so many causes of TAS, including endotoxin, residue, hand pieces, sterilization, talc, cottonify, so many things are there. All irrigating solutions. Even this prophylactic moxifloxacin which you inject, that also can induce TAS. I was talking to Dr. Rajesh Fogla. He said, you see, don't depend too much on intracameral moxiflox because there's a referral of toxic reaction in the endothelium are also pretty high. What is important is TAS develops very early. So next day, patient will have limbus to limbus corneal edema. So this is a patient of TAS. Whereas in infection endophthalmitis, unless it is fusarium or unless it's pseudomonas, will take 1 or 3 days to develop. But if it is within 12 hours and there's a limbus to limbus corneal edema, suspect TAS. The other point is in a patient of endophthalmitis, because of this cyclitis element, IOP is never high. IOP is generally normal or low. But in TAS, it may be raised also. So this patient I had shown in the beginning, the reason I loaded this patient steroids was that there was this corneal edema, and we kept this patient in our outpatient department, and ultimately this patient started showing some glow here. We documented, and then no internal antibiotics were given. Ultimately, after 2 weeks, this patient improved. This is the story of that young lady which I told operated RK and then very severe corneal edema. The thing which tilted my diagnosis was this whitish color of the vitreous opacity. If it is an endophthalmitis, generally color will not be whitish. It will be a creamish or yellowish kind of color. So this I thought was an eventful surgery with some lens droppings. So we loaded this patient with intensive steroids by all the possible routes. In fact, intravenous 2 cc decadron also we injected. And you see how much this patient improved slowly, this edema went away, pupils started dilating, and you have this lens matter which also got dissolved, and ultimately patient had good vision. So all these patients who rush to you for vitrectomy, you should take your time, evaluate, and then take a decision. Endophthalmitis, we all know, has to have vitreous exudates. Definition of endophthalmitis, apart from inflammation, it has to have exudation into the vitreous cavity. And exudation takes time. You see, if you do ultrasound in a fresh patient may be anechoic also. Because this clump opacity is, there is a minimal, 0.5 millimeter or so clump to form, then only will throw a signal. And organisms grown, we all know, but organisms in our country, I think, are more of gram-negative and fungi compared to what EVS had reported. So we have to be very particular about this, that fungi are more common in our country and gram-negative also. Signs and symptoms, these are listed, we keep tabulating. In a patient who has sterile reaction or inflammation, the vision drop will not be marked. If it's a marked visual drop, then you have to suspect infection. And PR inaccuracy also should tilt towards infection. Hypopyon can occur in both, actually. If it's a very severe TAS, hypopyon can occur in both. But pain and lid edema is severe in infection, but not in TAS. Similarly, as I said, color of exudates is generally whitish hair and yellowish. IOP generally low in infection and normal or raised hair. Then endophthalmitis will generally have a focal infiltrate from where the organisms have had ingress into the intraocular cavity. Fundus glow, again, if you can see the retina reasonably well, possibility of it is TAS is high rather than infection. So this tabulation we did a long time back, which can help you to tilt diagnosis in a patient who does not have all the telltale signs. So often patients may be in gray zone, whether it's TAS or infection. But what is important is unusual patient pain. You see, patient enters your OPD and he is having a hand here, pain बहुत ज़्यादा है डॉक्टर साहब. Or patient was doing well, say for first day, second day, but second day patient, third day patient has a drop in vision. So decreased vision after the gain, which does not happen in TAS. This happens in infection. Or patient has a lid edema and chemosis. Lid edema and chemosis also are signs of infection. You will not find a patient of TAS who will have lid edema or chemosis. Then corneal hypopyon, as I said, I have seen patients of TAS with hypopyon. But most important is obviously if there's an exudation in the vitreous cavity, that is 100%. But even then, if you can't, then always are on the side of infection. You will never regret giving intraocular antibiotics, but you will regret not giving intraocular antibiotics. So this is said, although all surgeons have their own gold standard because surgeon knows how much trauma has he caused. So I will ask patient, surgery mein time kitna laga? Because if the time taken is routine 5-10 minutes, it's okay. But if the surgeon has taken half an hour, 45 minutes in today's era, then something has gone wrong during surgery. So increasing pain, increasing reaction on the first post-op day, and decrease in vision after few days. So gain after dropping vision, vision going down after the initial gain is a sign for pain. Again, is not 100%, but 25% patient may not have. Because fungi are known to be silent, where signs are more than symptoms, patient may not have much pain. From the science point of view, always my OPD will start with distant direct, because distant direct gives you wealth of information if the glow is obscured or not. And secondly is the exudates in the vitreous cavity. So if there is a hypopyon and vitreous exudates, you are dealing with short endophthalmitis. This is short. But what if you can't see the vitreous? Often it is obscured. So what we pay attention is to these three things. What is the vision of the patient? How much you can dilate the pupil and see the wound margin. So based on these 3-4 things, maybe you can make. So if the exudates are there and diagnosis is confirmed, if no and pupil does not dilate, we see the AC reaction. If it is a marked AC reaction, a lot of cells, say 3-4 plus, and vision is also down, then in such patient we will advocate injection. However, the vision is good and AC reaction is also mild, maybe this will tilt towards TAS. So that is, it's a dynamic thing that you have to evaluate patient repeatedly also. So key issues are delay. We should, therefore diagnose it pretty early so that optimal treatment can be given appropriately. So we'll not go into the management at all. So aim was to, give some tips in diagnosis of postoperative endophthalmitis. So this slides again, last slide comes again, that these are the few tips for approaching a patient of endophthalmitis. Thank you very much for your kind attention.
Thank you, sir, for a wonderful presentation. I mean, we would love to, listen some tips regarding management of endophthalmitis also.
No tips. I think this talk was basically focused on diagnosis. But you see, early, I would advocate that all surgeons, irrespective of their specialty, should learn that technique of giving antibiotic injection. And the dosing and all are all available. But those intravitreal chart, which I had distributed 2-3 times, and courtesy Sipla, who helped me to, make this chart and post it to all. This chart should be stuck onto the OT wall. Prepare the drugs yourself. Avoid dilution errors, and take it as a serious intraocular procedure. And most of the times we do under topical. And as I said, if the organisms are sensitive and the response to intraocular antibiotics is very, very good. There should be no delay, because I remember one patient I operated just prior to a holy day, and next day happened to be a holiday. So went to see that patient had endophthalmitis. So had to open the entire OT and give it on the same day. You can't delay, you can't ask him to come on Monday. I still remember I went to Gurgaon, it was a Saturday, so had to do it on the same day.
So along with intravitreal injections, do you also give intracameral in some cases? Or
you can, because if the load of the infection is very high and AC is full of exudates, then yes. But by and large, intravitreal only, unless the AC is full of exudates, then I may. I do not mind overloading with antibiotics. I don't think so. They are so toxic to the retina. Aim is to save the eye and kill the microorganisms. So I will, you are right, that give some part in the AC also. Because in any case, you see, once you are giving two antibiotics, you have to decompress. And the best way to decompress, apart from biopsy, is AC paracentesis. So at that time, you can give.
Suspected DAS or endophthalmitis.
Yes.
Actually, I have patients who develops vitritis after 15 days.
After?
15 days.
Of cataract surgery.
Cataract surgery. Only vitritis, this visible implies also grade 2 types of vitritis. I will started a steroid. After 10 days, vitritis resolved. But again, after stopping, after tapering the steroid to lower it 20 mg or 10 mg, patient again develop vitritis again. It is what I have to suspect. It is DAS or endo.
So most likely it is a low-grade endo. Low-grade endo, because all eye tests will respond to steroids. You see, remember, endophthalmitis also has inflammation. It's inflammation plus infection. So if you give steroids, inflammation part will come down, you will have some improvement, especially in your patient where there's only vitritis. So you give steroid, but vitritis is an anatomical diagnosis. It's not a short etiological diagnosis. So if a patient is repeatedly having infection, you should do a vitreous biopsy and tap to find out. A lot of times you may become wiser. But if the patient is, recurring after you are tapering the steroids, you should rule out infection, because most likely it's a low-grade infection which is causing an issue. What I would do is I will do during the vitreous biopsy or taking a tap from the vitreous, do a vitrectomy also, and at the end of vitrectomy inject antibiotic. So most of the times we are still persisting in low grade. We still persist with the Vanco and Kefta. Unless it's a virulent organism, then we go to tazobactam and piperacillin.
One thing what I'll like to reiterate that the diagnosis is key. And I can tell you, if you diagnose and inject at a proper time, 85% of the patient will return to 6/6 vision. Only 10 to 15% patient undergoes worsening and further vitreous surgery. And if you diagnose, there is a thing what we call as a minimal inhibitory concentration. If the eye is full of exudate, then no intravitreal will work. If the load is less, then only the intravitreal antibiotics will work. So diagnose and give it, and 85% to 90% of the patient, you will be able to salvage the eye.
So if the load is very high, then I start preparing mentally the patient for vitrectomy also. I may give intravitreal, but I start preparing. I tell him that the amount of load is so high that you have to, it's like an IND, you have to take out this bulk. And then the antibiotic penetration, the response also will improve. If you allow this so much of bacteria and exudation inside and give intravitreal, it may not work. So like Vrinder was saying, you have to debulk, inject antibiotics, and sometimes silicone oil also, depending on whether the retinal surface is loaded with exudates or not. If the exudates are on the retinal surface till the ora serrata, then ultimately I inject silicone oil also. The advantage of having silicone oil after a radical vitrectomy is that silicone oil per se that you inject 4 cc or 3 cc is impervious to any kind of microorganism. So what is there? Here is the retina. So this small space between the oil and the retina you can take care of by intravenous antibiotic or oral. Whereas space in front of the iris you can load with topical, what Rajesh told, concentrated drops of, Cefa and Toba or Amica, that will take care.
Finally, the antibiotic has to work. If the antibiotic does not work, you can't cure with vitreous surgery. Even one bacteria can grow over a period of time and cause a lot of exudation. So you have to find a sensitivity, and antibiotic has to work to get a good results in any of the case of endophthalmitis.
Yeah, yes.
Do you do both AC tap and vitreous biopsy? And if you do vitreous biopsy, do you use a 25 gauge?
Yeah, so I don't do both actually. If I am doing a vitreous biopsy, I do not do AC tap at that time, because the only reason I said vitreous tap is AC tap is because people who are not well versed with the vitreous biopsy, because I don't advocate putting a needle inside and sucking the vitreous. That is not good. So vitreous aspiration is out, vitreous biopsy is in. Vitreous biopsy, other advantage is the yield of microorganisms is higher than doing an AC analysis. The AC problem with AC is that the microbial yield is less. Vitreous biopsy, the possibility of growing any organism by culture is higher compared to an AC tab. AC tab we advocate only for people who are not very well versed with the antibiotic, but you have to decompress the globe, because you can't inject 2 or maybe 3 antibiotics without decompressing. Otherwise, the CRA is at risk, central retinal artery is at risk. So vitreous biopsy is the choice, there's no doubt.
With this,
But
if
it's very rare that you will have different organisms from vitreous and AC.
With this, if the audience does not have any question, we'd like to close the session. We'd like to thank Dr. Lalit Verma, Dr. Harbans Lal, the Doyens of Ophthalmology, and Dr. Rajesh Sinha for giving us vital tips in day-to-day practice, how to manage it. And it's basically practical tips which works in your day-to-day practice. Thank you very much for staying with us.
Just wanted to inform everyone that, this term, as I was mentioning earlier, once we were sitting and Lalit sir only coined this term tips, that is tip in practice. So what exactly we need in practice, that we should know. So that's how we have been doing this session earlier also. And it's wonderful to have tips from people like him, from Amninder and everyone. So thank you very much for being a part of it and giving your inputs and feedbacks.